So when I talk about the first session, vaccination in pregnancy. So whenever I talk about vaccination, I have to understand it has various types of vaccines. There are various types of vaccines that are available. The first one happens to be my toxoid. I'll also place under it conjugate vaccine. In that, basically, I'm taking a part of the an immunogenic but non-virulent part of the virus or the microbe is taken, and the vaccine is made out of it, a very safe vaccine per se. Then I have inactivated vaccine, heat inactivated vaccine. And lastly, I am going to be having something that is absolutely contraindicated in pregnancy unless there are exceptional circumstances that happens to be a live vaccine. So these are completely contraindicated, and except a couple of instances, they are never going to be used in pregnancy, whereas inactivated and toxoid as well as conjugate vaccines are going to be frequently used. So let us begin with the toxoid one. So in toxoids, the commonest one that you will encounter is going to be your TT. Nowadays, in government setups, you are also getting TND, that is tetanus toxoid and diphtheria toxin. Apart from that, if your patient is ready to spend a bit, then they also get something called as Tdap. Tdap happens to be tetanus, diphtheria, and acellular pertussis. Now, acellular pertussis you must have last read in your pediatrics, wherein they call it as the painless one, although it is not really painless, but they call it the painless vaccine that is given to babies. But these are the three types of vaccines that you're going to be getting in the market. So for tetanus toxoid, you first need to remember that an ideal dose consists of two doses 1 month apart. So two doses 1 month apart at least can be given. A few people tend to practice that they prefer giving this vaccine in the second trimester, third trimester, but I don't see why should you not give in your first trimester, especially if you're practicing in a government in a civil setup wherein your patient may not be compliant, your patient may not come back for another 3, 4 months. So it is always good that you give it on the first visit if they are absolutely not immunized. But what do I mean when I say they are absolutely not immunized? So when I say they are not immunized, it means that they have not been vaccinated for the last 5 years. And the other option is if they are not vaccinated for the last 10 years. But 10 years wala criteria applies if they had no injury in those 10 years or it was just a minor injury. Whereas if in the last 5 years they had some major injury, in that scenario, 5 years is going to be sufficient. If your patient has come in the span of less than 5 years since the last vaccine, all you give is a booster dose. Booster is a single dose. Whereas for this, you're going to be giving two doses. So 5 to 10 years के बीच में है अगर last vaccination का history and there was some major incident, major injury, major accident that had happened, then I'll be giving a full course. Whereas if there has been absolutely no such history and it has been more than 10 years, then I'll be giving a full course. That is the basic. The other one is, and by the way, this is very similar for TT and TD. For Tdap, it is a little different. When I say different, I intend to say that in Tdap, the point here is that this acellular pertussis is not for the mother. Whooping cough or pertussis is a deadly infection for the babies and it can even cause neurological complications and even death. I do not want that to happen. So what I do is I give the female, the mother, a vaccine at such a time in which she will be able to produce, she'll be able to do seroconversion in her own body. What do I mean by seroconversion? I mean that once I've given her that toxin, her body is going to first develop IgM and then that is going to get converted to IgG. Now, IgG is the one that is going to cross the placenta and is going to go to the fetus. IgM will not go. So I need to give the body adequate time for the mother to make IgM and then it will pass to the fetus. And that fetus is going to be protected with that maternal IgG. Basically, that passive immunization is going to protect that baby for the next 2 years. So 2 years of its life. So very important, crucial period of childhood is covered, and hence this is ideally given the first dose at 27 weeks and the second one is given at 36 weeks. Very important. All these are going to be given as intramuscular injections. Nothing much that is difficult to be. There is nothing much difficult in this. The next happens to be my HBsAg. So HBsAg happens to be a conjugate vaccine and the full course is going to consist of 0, 1, and 6. What do I mean by 0, 1, and 6? It is just that I have to give a vaccination thrice First, if I'm giving it today, the next one is going to be a month later, and the last one is going to be more than six, after 6 months from today. Again, intramuscular injection. Now, one interesting point that you have to note over here is that, and it is something that one of my colleagues had faced very recently, and that was she just got pricked. She's pregnant and she got pricked by a patient while doing a surgery, by doing a CS, a cesarean section. She got pricked, and the patient turned out to be HBsAg positive. So she asked, "What do I do next?" Now, this is not something that is given in your books, but it is something you need to know, and that is going to be whenever you or any of your colleagues who are doctors are getting pricked, or if you have a patient who is well aware and that patient who is not a doctor but is well vaccinated, if they're going to get pricked, HBsAg अगर पेशेंट है तो मैं सबसे पहले क्या करूंगा, मैं जाके बोलूंगा एंटी एचबीएस टाइटस चेक करो, एंटी एचबीएस टाइटस चेक करो। एंटी एचबीएस स्टेटस चेक करने के बाद में कितना वैल्यू आता है मुझे बताओ। इफ द वैल्यू इज मोर देन 100, देन आई डोंट नीड टू डू एनीथिंग। It indicates that your body is safe and it has lots of anti-HBs titers, by the way. Yeah. So your body has lots of antibodies, so you don't need to do anything. If the value is between 11 to 99, or rather 10 to 99, in that scenario, you need to be taking in just the active immunization, that is HBsAg vaccine, full course. Whereas if it turns out to be less than 10, in that scenario, you need to do two things. First is going to be HBsAg भी लेना है पूरा course, plus you have to take HBIG, that is immunoglobulin. HBIG is immunoglobulin, and that is like passive immunity that you're giving to the patient. So depending on the titers, this is what you'll be doing. Now this is going to be the same for any patient, be it a pregnant patient or a non-pregnant patient. Do not worry. IVIG or immunoglobulins are safe in pregnancy. The problem that they can cause is that they can lower immunity, but then they can lower immunity even in a non-pregnant patient, and that is not significant. So yes, definitely do not think whether pregnancy will have any contraindications. Immunoglobulins can be given in pregnancy as well.